So let me share a video. So this summarizes the kind of work that we are doing at Aravind in the past few years. So let us move on to the video. So this is a case of traumatic dislocated lens wherein we've done the lensectomy and now we are moving on to XNet part. So you're seeing on either sides I'm doing the scleral grooves. These days I normally use the bent side port knife. So the idea is you kind of get a triangular sort of scleral groove with a broad entry, and it as you go distal it becomes narrower. So the broad entry is easy for tucking the aptic at the end of the surgery, and since it's narrower at the end, so there's no question of aptic dislodgement or aptic migration in the post-op period. So once this is done on either sides, 180-degree apart, so we can move on to XNet. So basically, XNet is all about exteriorizing the aptic in a very simplified manner without any intraocular maneuver. That seems to be the toughest task for doing esophageal, especially for a novice surgeon or an anti-segment surgeon. Always they have the fear of fall. So this is what triggered us and bringing out this technique. So you can see now this is essentially an unedited video. And now what the green thing what you're seeing is the XNet needle, XNet device. The back side of it, you can see the sclerotomy markers that we have provided. That's a 1.5 mm marker. So you can just before making the sclerotomy, you can have an quick idea. And you can this is a customized needle. The length of the needle is 17 mm, whereas the conventional needle will give you conventional 26 gauge will give you only 12 mm. So once you go inside, initial directions towards the mid-vitreous, then you change the direction at the pupillary plane. Try to come anteriorly and come towards the corneoscleral section that you have made already. So the current version of XNet requires a larger section. We don't really recommend XNet for clear cornea or foldable esophageals for practical difficulties. We're still working on it. So you should not try to penetrate and come out. All you need to do is just sweep. Just sweep. When you complete the arc, the tip of the needle will be outside, and you can use a McPherson like this to prevent any entrapment of tissue over there. And once you see the tip of the needle, all you need to do is take the 3-piece IOL. The aptic of the 3-piece IOL is docked into the lumen of the 26 gauge needle. 4 mm of docking is generally adequate, not more than that. So once you do that, as you can see, each and every step that I'm showing now can be easily done by any surgeon, anterior segment surgeon or posterior segment surgeon, or a novice surgeon. Anybody can do it. The learning curve is really short. So once the docking is done, gently retract the needle. Gently retract it. At the same time, push the IOL inside. It should go as a single unit. Don't retract separately. Don't push separately. Do that gracefully together. So you're retracting the needle, at the same time you're pushing the IOL. And you can see we're not going to do any intraocular maneuver here. We do something outside, and we're going to do something again outside at a different location. So now this needle aptic complex is gone inside. So now we are going to exteriorize the leading aptic. So using a McPherson forceps, you can, what you see, the circular thing is the dual protection silicone stopper that we have provided. It's everything's pre-loaded. You don't have to do anything. You just take the device and use it. So take it close to the sclera using the McPherson forceps. Keep the McPherson forceps inside the foramen of the stopper. Wait for the aptic to come. Wait for the aptic to come. Retract the needle gently. So once you see the blue portion of the aptic, gently hold it and try to disengage the needle. So you can see simply at one go, the dual protection silicone stopper has been changed to from the shaft of the needle to the aptic. So this stopper, the idea of the stopper is to eliminate your dependency on the assistant. It temporarily stabilizes the leading aptic when you are going to maneuver your trailing aptic. So once you do this, you can actually move the silicone stopper to the very tip of the aptic and take it close to the sclera. That's what I'm doing now. You can see that. As it was discussed by the previous speaker, trusting your assistant is very critical. If you have a trusted assistant, that's great, but you may not be lucky at every time. So I generally use a silicone stopper. So when we do that, when we push it close to the sclera, you get additional intraocular length of the aptic, which helps in maneuvering your trailing aptic. So you can do the same thing on the other side. You may slightly increase the intraocular pressure at this stage for easy penetration, or you may simply close the lip of the corneoscleral section using a cotton tip applicator so that your penetration is easier. Once you do that, once the tip of the needle is inside, you need to again sweep it towards a corneoscleral section. Remember that the plane of your sweep should be above the aptic and above the optic. So you can again use a McPherson forceps here at this step. Sorry, I think there is. Let me adjust it. Yeah, got it. So you can use a McPherson forceps here to gently depress the corneoscleral lip and do a sweeping motion. Remember, we should not engage any tissue here. So it's very important that you don't engage any tissue over there. Otherwise, there will be an issue when you are bringing the aptic out. So you can probably once you are out, you may do a lateral motion to and fro and ensure you are free, that the needle is free from any tissue over there. So once you do that, now you can simply retract the trailing aptic. And normally I flip the McPherson forceps reverse and gently retract and push it inside to the lumen of the 26 gauge needle. This is like, our aeroplane landing on a runway. The tip of the trailing aptic should be facing downwards. At the same time, the lumen should be receiving it. It should be, you may slightly depress so that you just receive it. So what you need to do is you just simply hit the lumen and give a slight pressure so that it gets into the lumen well. So again, 4 mm of docking should be fine. Once you are comfortable, you retract the needle. Again, we are not going to do any intraocular maneuver. You can clearly see that. So now, we are going to exteriorize the trailing aptic. Take your McPherson once again. Go to the sclerotomy site and wait for the aptic to come. Gently retract the needle. So wait for the aptic to come. So it's a good idea to, again, catch hold of the aptic gently and then disengage the needle. The idea is when you do it without holding the aptic, what can happen is this stress can sort of have an impact on the other side. So because of the silicone stopper, your leading aptic is safe, but the aptic optic junction may give way. So that shouldn't happen. So it's a good idea to hold the aptic like this and disengage. So that gives a very clean exteriorization. So you can clearly witness that the aptics are absolutely intact, especially the tips are absolutely intact because we have not touched the tip at all. This is critical. Sorry, my video is again. Yeah. So this is critical because imagine if the tip is distorted, it's very difficult to push it into the narrow scleral groove. So it's very important that you safeguard your tip. As you can see, now I'm pushing into the scleral groove which I have made. I normally follow what Gavauche area has taught us with a slight modification. I keep a broader entry, but you can always combine XNet with glued IOL. You can create a flap here and push it inside, or you can do emanistic. You can create a flange and fix it. So that's up to the surgeon. But exteriorization is definitely made simple with XNet. That's the point we are trying to show here. So you can do the same thing on the other side. So one important tip that I would say is when you're pushing the aptic into the scleral groove, it's very important you note the movement of the optic. Whether the aptic goes inside or not is assessed by the movement of the optic. If the optic turns as you're pushing inside, definitely your aptic is going into the right plane. So that sort of ensures that your tucking is fine. That's very important for your long-term stability of IOL. So that's something that everybody has to keep in mind. So yeah, that's it. We're still working on the ways to simplify the aptic fixation. Very soon, probably will come out with a device. Yeah.